portrait of the development of his obsessive compulsive disorder, from its emerging symptoms to his struggles with severe symptoms in middle age. It tells a story of his lifetime achievements as well as a filmmaker, an aviator, a record breaker, a playboy, and a successful entrepreneur. These successes were probably aided by his extreme professionalism and his determination to attend to every small detail in a project, something the film illustrates brilliantly. In this instance, in this film, I would diagnose Mr. Hughes with obsessive compulsive disorder, with fair insight, with panic attacks, and tic related. Mr. Hughes meets all of the following criteria from the American Psychological Academy's DSM-5, which states: A, presence of obsession and or compulsions. Mr. Hughes, in his case, has both. Mr. Hughes's obsessions are recurrent, persistent, and unwanted, and cause marked anxiety and distress. He attempts to suppress the obsessions using tissue paper between his hands and also using the tissue paper to cover his mouth. Also to neutralize them with other actions, such as performing compulsions. Mr. Hughes feels driven to perform repetitive behaviors or mental acts, such as repeating words and counting phrases, in response to obsessions according to the rules that must be applied rigidly and are aimed at reducing anxiety. B, obsessions or compulsions are time-consuming, cause clinically significant distress or impairment in social and occupational functioning. C, symptoms are not attributed to a substance or other medical condition. And D, the disturbance is not better explained by any other mental disorder. Now, a couple of the differential diagnoses that I've come up with was number one, psychotic disorder, brief psychotic disorder, schizophrenia, schizoaffective disorder are all differentials that should be considered in his case. His hallucinations, delusions, bizarre behavior, disorganized thoughts, disheveled appearance, and inability to complete goal-oriented tasks are indicative of something more than OCD, likely schizophrenia or paranoid schizophrenia. However, it's difficult to diagnose the patient without further evaluating the duration and pervasiveness of the symptoms. For instance, in schizophrenia, the disturbance must be evident for 6 months, and there is not enough evidence to confirm this in his case. It is, however, very likely that Mr. Hughes meets criteria for schizophrenia, since he portrays many positive and negative symptoms. Next will be obsessive compulsive personality disorder. Mr. Hughes does not fully meet criteria for obsessive compulsive personality disorder, although many of his symptoms could be argued to represent both OCD and personality disorder alike. About 23 to 32% of people with OCD also have obsessive compulsive personality disorder, according to the APA. So it could be possible that he has both. Although the characteristics of a perfectionist, he does not portray a pervasive pattern of preoccupation with orderliness or neatness. Rather, he was preoccupied with avoiding germs and contamination. At this point in time, Mr. Hughes does succumb to mental and interpersonal control at the expense of completing a task, not eating until his food is prepared and delivered perfectly, and making sure it's delivered perfectly clean. This could represent both OCD and personality disorder. His repetitive behaviors and obsessions are more characteristic of OCD. Thirdly would be anxiety disorders and specific phobias. Mr. Hughes does not meet the many criteria for generalized anxiety disorder. However, the APA states the symptoms cannot be associated with another mental disorder such as OCD. Also, the recurrent thoughts that are present in generalized anxiety disorder are usually about real-life concerns, whereas the obsessions of OCD typically involve odd or unusual concerns. Additionally, compulsions are apparent in his case, which would not be apparent in anxiety disorder or specific phobias. Lastly, Mr. Hughes' fear of crowded and public places is related to his obsession with contamination rather than the fear of social situations itself. Another one would be major depressive disorder. More information is needed to be able to diagnose Mr. Hughes with a major depressive disorder or major depressive episode. While he meets many of the criteria for major depression, it is sometimes unclear whether the symptoms are related to depression or OCD, and symptoms cannot be counted for both, according to the APA. While he did seem depressed after Kate visited him, there is no indication for the length of time that these feelings lasted. And finally, depression can be associated with anxious, distressed, mixed features, or psychotic features, which further complicates diagnosing this condition. Also, bipolar I disorder. The most recent episode depressed, severe with psychotic features. It could be argued that Mr. Hughes' impulsive behavior, ambition, and as well as his insomnia are characteristic of bipolar disorder with current episode of depression. However, patients' obsessions and compulsions are indicative of OCD rather than bipolar. However, it is common for an individual with OCD to also suffer from depressive or mood disorders, according to APA. So this option should be ruled out without further evaluation. Lastly would be tic disorder. Mr. Hughes does not meet criteria for tic disorder because there is no evidence of motor or vocal tics being present before the age of 18. Which is required for the diagnosis according to APA standards. If confirmed tics were apparent early on, then he would meet criteria for persistent motor or vocal tic disorder. This is a common finding. This common finding is up to 30% of individuals with OCD have a lifetime tic disorder, according to APA. Comprehensive treatment recommendations. A combination of pharmacotherapy and behavioral therapy should be considered for Mr. Hughes and is likely to produce the best outcomes, in my opinion. Effective medication options include serotonin-specific drugs like SSRIs, for instance Prozac, Paxil, or Zoloft. If he does not respond well to these alternative medications, then other strategies may be considered. Now, the treatment that I would recommend for Mr. Hughes would be the following. Number one, consider an intensive outpatient or inpatient anxiety management program that employs the evidence-based treatment. Number two, psychiatric consultation to initiate pharmacotherapy for managing OCD symptoms. Number three, weekly cognitive behavioral therapy to identify and manage obsessions, compulsions, as well as panic attacks. Number four, as anxiety management improves, we could target residential substance abuse problems via psychotherapy, support groups, or possibly other sources. Number five is psychoeducation. This would be used for lifestyle changes, nutrition, and general self-care and hygiene. The reasons that I chose this treatment is because cognitive behavioral treatments have been developed in the past 2 years, or 2 decades, should I say, are very effective in treating the symptoms, using either exposure and response prevention. 3 out of 4 people are helped significantly, or cognitive therapy, which is very effective for mild OCD on its own. Additionally, there are thought to be problems with a neurotransmitter serotonin, which is deficient in certain brain areas of people with OCD. This explains the use of certain drugs in the SSRI group of antidepressants, which increases available levels of serotonin in the treatment of moderate to severe OCD. Even when depression is not present, People who find relief with medication alone, which is usually about 6 out of 10 people according to statistics, tend to relapse when it is stopped, unless it is combined with CBT. Now, when I was looking at Mr. Hughes and watching this movie, I did notice several strengths that Mr. Hughes had, which definitely come into play when looking at the different treatment modalities that I would use. He's very creative. He's an innovator. He's organized. He pays a lot of attention to detail. He's a pioneer in aeronautics. He's well-spoken and intelligent. He's a goal-oriented thinker. Because of these particular strengths, Mr. Hughes needs to be approached with an attitude of respect, positivity, and hopefulness. There's a general assumption that people are strongly resilient and continuously utilize this to make changes. And I believe this would also be the case for Mr. Hughes. Furthermore, there is a strong belief that most people have the strength, wisdom, and experience to effect change in their own life. Looking for previous solutions for Mr. Hughes that Mr. Hughes could use to manage his problems, even though the problems may have come back, he was able to solve his problems for a short amount of time. Validating the solutions that Mr. Hughes has already created to help with his problem, in my opinion, compliments in therapy sessions can help to punctuate maybe what he is already doing that's working for him. So it just kind of helps to kind of punctuate that. I also believe asking questions that are always present, future focused questions. We don't want to dwell on his past problems, but we want to focus on the present and the future and what changes that Mr. Hughes feels can be helpful to him and help him to be more resilient. Now, as far as family therapy, I also feel like family therapy is very important here. It would be very beneficial for the people who are closest to Mr. Hughes for providing emotional support and education on how to manage and respond to him and the things that he's going through. Due to the intensity of his illness, it does not seem likely that Mr. Hughes would commit to any type of outpatient therapy or inpatient therapy, or it also probably wouldn't be likely that he would stick to a regimented medication schedule without some type of possible assistance. Hospitalization would be something that I would advise to possibly help Mr. Hughes to get him out of the external environmental stresses that he may be facing. If hospitalization is refused, I would possibly consider a home health nurse or a 24-hour caregiver who can provide more one-on-one care, for him. In conclusion, I would like to mention that this film portrays clearly that Mr. Hughes' obsessive-compulsive symptoms fluctuated significantly in severity in response to the stresses and the traumas in his life, especially his near-fatal plane crash. But even during the worst episodes of his earlier life, he was able to suppress the symptoms fairly effectively when totally absorbed in a particular task. The complete focus and absorption required to fly a plane seemed to overcome his symptoms and gave Mr. Hughes some of the happiest experiences of his life. This makes sense to us now because the effective treatments involving mindfulness in the present moment and distraction into activities are known to help lessen some of the symptoms that are present in OCD. I believe that this film offers the viewers an opportunity to gain an empathetic understanding of the suffering that individuals with severe OCD might experience. Indeed, one wonders what further achievements that Mr. Hughes might have made in his later years had he been able to access these treatments that we have available, today, when he first developed these symptoms early on. looking at his life and looking at the things that he was able to accomplish, there's no telling how far he could have went, what kind of things he could have done if he would have had the help and been provided with the assistance that we can provide people with OCD, in today's society. So this was a great experience for me to be able to look. It was a great movie, by the way, the first time I had ever watched this movie. And I did notice a lot of different things in there. I do have patients that I deal with OCD. And going through this activity, going through this movie, actually helped me to learn some different ways that I can deal with some people that I work with that have obsessive compulsive disorders. So it was very very interesting, very educational to me, and it was just a great experience. I look forward to actually using some of these techniques, some of the things that I was able to look at Mr. Hughes and say, okay, I would use this for him, and I think this would be beneficial to him. So I obviously look forward to using some of these things along with my patients and seeing how well they could do and how much they could improve. Again, this was very educational. I learned a lot in it, and I really appreciate this opportunity to speak on OCD and to speak on this movie, The Aviator. Thanks a lot.